Welcome aboard the Just Help Out Mindset podcast, where your compassionate guide, Nicole Venegas, takes the helm. Brace yourselves for an immersive experience as we delve into the heart of crucial conversations. We're set to explore the intricacies of suicide prevention, navigate the landscape of mental health, and boldly shatter the stigma surrounding therapy. This isn't just a podcast, it's an odyssey of resilience and understanding. Join us on this transformative journey filled with stories, insights, and a collective mission to create a world that embraces the strength of empathy and helping others. Fasten your seatbelts. We're about to embark on a voyage towards a healthier, more compassionate existence.
Welcome to Season 2 of the Just Help Out Mindset podcast, where we are breaking the stigma around mental health one episode at a time. This podcast was formed from our nonprofit, the Just Help Out Foundation, based in Tampa, Florida. It was created from the devastating loss of my only sibling, Joey, who died by suicide on May 3rd of 2022. The world lost a beautiful soul that day, and he has forever left a void in our hearts. The Just Help Out Foundation works tirelessly to combat suicide and help people understand that asking for help is not a sign of weakness, but in fact, the opposite. It is a courageous and respectable act. Each guest on the show this season shares insightful experiences in their own personal lives and helps guide you in the journey we call life. Try to be in the present moment and clear your mind while we go on this adventure together. Welcome, listeners, to another episode of the Just Help Out Mindset podcast. I know I say this all the time, but in the studio today, we have truly a phenomenal guest. Listeners have even reached out to request this topic be discussed on the show. Today, live in the studio, we have Mark Ruffalo. He has his master's in social work and his doctorate in psychoanalysis. He is a psychotherapist in private practice in Tampa, Florida, and he serves as an instructor of psychiatry at the University of Central Florida College of Medicine, and he is an adjunct instructor of psychiatry at Tufts University School of Medicine. He has a broad clinical experience in the psychoanalytic treatment of mood disorders, personality disorders, and psychosomatic illness. And he has a particular interest in the psychotherapy of schizophrenia. He was also once on MSNBC as a guest speaker discussing violence and mental health. During his training at the University of Pittsburgh, Dr. Ruffalo had the unique opportunity to work with severely ill patients in long-term psychotherapy, an area in which he has developed internationally recognized expertise. He has published previously in, are you ready? The American Journal of Psychotherapy, Psychoanalytic Social Work, Psychiatric Times, and the Primary Care Companion for CNS Disorders. He currently serves as co-director of the psychotherapy track at the UCF HCA Healthcare Orlando Psychiatry Residency Program and is editor-in-chief at the Carlet Psychotherapy Report. My goodness, Dr. Ruffalo, welcome to the show. What a phenomenal resume. I am so excited that you are here today.
Thank you so much for having me. It's great to be here.
Your expertise is something that is always asked about, and lots of confusion in this area because it's a difficult diagnosis. And the personality disorders, if people are in relationships with this or they have them in their family and they're not sure what the actions are equaling, which is what we're going to dive into. But please, can you explain just a little bit about what is borderline personality disorder? What is narcissistic personality disorder? How are they different? How do they overlap? And just kind of give us like a baseline lesson.
Yeah, sure. So both borderline and narcissistic personality disorders are considered cluster B personality disorders in the diagnostic manual. That's the DSM, the book that we use to diagnose mental disorders. The third disorder included in that group is histrionic personality disorder. There's a significant overlap between borderline and narcissistic pathologies, and that's been known for quite some time. And the pioneer in this area is a psychiatrist named Otto Kernberg, who really transformed treatment of these conditions. So to start, borderline pathologies are marked by an unstable and chaotic patterning in interpersonal relationships. Often an intense fear of abandonment and rejection, alternating with fears of engulfment or enmeshment or fears of intimacy. And this often leads to a chaotic push-pull pattern in relationships where the patient, sort of with their romantic partner, pulls the other person in close and tells him or her, "I'm so in love with you. You're the best thing that's ever happened to me. I could not imagine life without you." And then a short period of time later engages in what we call devaluation, which is basically seeing the other person as no good, as worthless, as not being important at all, as being evil, an abuser, etc. And the patient sort of alternates between idealizing the other person and devaluing the other person. And a lot of borderline patients refer to these other people in their lives as favorite persons or favorite people. And this favorite person becomes an external regulator of emotions, that how the patient feels that given day depends almost entirely on how the relationship with that favorite person is going. A lot of my work in the area of borderline personality disorder has been on the individual's self-contradictory behavior, paradoxical behavior. In essence, psychologists in the 70s described something that he termed cyclical psychodynamics, which is where the patient unconsciously elicits behavior that is the exact opposite of what their stated intention is. So, paradoxically, they may do things to drive the other person away, yet they are saying that they want them close by making accusations, by testing the partner in various ways, by essentially stirring things up, being critical, and the like. And I've recently written a paper on communication dilemmas in borderline pathologies, in which the patient sort of engages in this characteristic way. Narcissistic personality disorder is also a cluster B disorder, often seen in men, but also seen in women. Historically, borderline pathologies, by the way, were considered female disorders largely, but we now know that men also suffer almost to the same in terms of the percentage of the population, almost the same in terms of the gender ratio. But narcissistic personality disorder, the way I like to think of this condition is that it exists, narcissism exists on a spectrum from healthy narcissism, which is essentially a sense of confidence in the world, a sense that we are competent at what we do, feeling good about ourselves most of the time. And at the extreme end of this spectrum is what we call pathological narcissism or narcissistic personality disorder, which is essentially excessive self-love. It's important for us to love ourselves, but in narcissistic pathologies, there is an excessive self-love. Often it is a means of defending against deeper feelings of inferiority and inadequacy in the world. So when you look at the histories of narcissistic patients, often you see that the narcissism developed as a defense mechanism against more painful affects. And narcissism is an effective defense in the sense that that it can, effective meaning that the individual rarely, if ever, feels those deeper painful emotions, those feelings about self. And they come off to the world as being grandiose and self-centered and into themselves, and they want to talk about themselves and their achievements, and they associate themselves with high-status people and institutions, and often interpersonal relationships with these people are also quite difficult. They, similar to borderline patients, engage in certain types of defenses, projection being one, splitting. We'll talk about these perhaps, but so there is significant overlap in borderline pathologies. You do see some narcissism as well, and the narcissistic patient is similar in some ways to the borderline patient too.
And given those descriptions on both of those personalities, both would be extremely confusing, I think, to be in a relationship with. So, and then the other person not knowing that they have this disorder thinks it's them, and they are experiencing all these different things. Now, when the person in the relationship is depending on that favorite person as their external regulator for emotions, how does that affect the person they're in the relationship with if they leave?
Well, first off, it can be absolutely exhausting and confusing, particularly this paradoxical behavior that I speak of, the push and the pull. I'm not really sure which partner I'm going to get today. Does she love me or does she hate me? So confusion, obviously. I mentioned I recently wrote a piece on communication dilemmas, and often in borderline pathologies, we see something called the double bind being utilized by the patient unconsciously. They're not choosing to do this, but in double bind communications, essentially you have a situation in which you relay two conflicting messages simultaneously, and it leaves the other person in a state of confusion. So an example of this would be what the psychologist Glover called a covert contract. A covert contract is where person A makes a contract with person B in their own mind about something person B should do for them. So a woman says, well, I think that my partner should get me flowers tonight, but doesn't express that expectation to the partner. Now, when person B walks in the door and doesn't have a bouquet of flowers, person A is upset and says, in essence, well, you don't care about me, you don't love me anyway. And that's what Glover called the covert contract. So confusion, doubt, uncertainty, and then ultimately, often you see in the partners of borderline patients a sense that one is losing their own mind. Now, the partner may not be so well or healthy himself or herself, and there's extensive literature in the psychoanalytic world about people with codependent problems finding themselves with borderline patients, and also narcissistic individuals finding themselves with borderline people, because the borderline person idealizes and in the initial stages of the relationship expresses intense love and infatuation and obsession, and the narcissistic person is fed by this supply, if you will, to use a common term.
So exhausting to even like go through this in your mind, just to think about what they're thinking about all the time. And in the covert contract, so basically they're making up a story in their mind, thinking that the partner should know what is in their mind, and then the partner doesn't know because it wasn't communicated, and now they're degrading their partner. Exactly. And now there's a fight.
Yeah. Another example of this is what the psychologist Paul Watzlawick in the 60s called the be spontaneous paradox. And he said that this occurs when one person requests or demands of their partner something that has to come spontaneously. So, for instance, tell me you love me, or you should initiate sex more often, or if you really cared about me, you'd hold the umbrella for me, right? So this puts the partner in a situation where if they do what they are asked to do, the person will say, well, you're only doing that because I told you to. You don't really love me. You're just having sex with me because I told you to. I want you to initiate sex. And if person B, that the partner doesn't do what they're asked, then person A turns around and says, well, you don't care about me. So there's a history here of an investigation of sort of different ways of communicating that plays out in personality disorders. And this holds true in my estimation also for narcissistic disorders as well.
For these disorders, I know you had talked about the fear of abandonment underlies a lot of these disorders. So would you say these are genetic predispositions, or are these learned behaviors from their childhood based on their caregiver and the whole attachment theory style?
Yeah. So most of the research nowadays, it's kind of generally accepted that about 50% of personality is inherited. The other 50% of personality is the byproduct of environment and parenting and attachment disturbances in attachment in early life and the like. For borderline disorders, there is a very high rate of childhood abuse and neglect, particularly sexual abuse in childhood. And in narcissistic disorders, often you also see very difficult childhoods and situations within the family dynamic. As a psychoanalytic therapist, I tend to focus mainly on the environmental or the psychological causes of these problems. But there is some evidence to suggest that, for instance, something like narcissism, pathological narcissism, is at least in part inherited. And you do see this often in the family histories of narcissistic patients.
Have you ever seen where the patient had a good childhood and parents were loving and nurturing, and they still have the narcissistic or the borderline tendencies?
You do see that. It's I would say, in my estimation, it's rare. And often when you dig a little bit deeper, when you really examine the early life of the patient, you do see that perhaps it's not as perfect as they claim it was. And I think patients can sometimes be defensive in this way. But yes, there are cases that have been reported, and probably most mental health professionals have seen individuals who seemingly come from good homes and good family environments who still go on to develop these types of disorders. And it's a question mark there. Is it a combination of genes and environment? In these cases, is it entirely genetic? Would the patient have developed a disorder regardless of what type of environment they were raised in? These are sort of unanswered questions.
These are very, very tough, tricky questions. And I'm wondering myself, as I sit here listening to your brilliant mind, are you constantly psychoanalyzing people?
It's an interesting question. People ask me that all the time. Honestly, when I close the door at my office, when I leave for the end of the week, I try to turn it off. I mean, I'll read and I'll write a little bit, but if I'm engaging with you, outside of work, you're not paying me, so I'm not doing any work.
Do you notice yourself if you're out in public at a social setting and you're seeing some odd behaviors, you find yourself diagnosing them?
I think we're all sort of guilty of that a little bit, but the key when it comes to psychoanalysis as a discipline, it's really impossible to analyze any behavior without knowing the history, without really knowing the person or the patient. So, I might come across someone who seems a little bit manic, for instance, but anyone would, even an untrained person would realize, wow, that person's speaking very quickly and they're, they don't seem just right. So,
do you see a cross between, I'm not sure if like bipolar and borderline personality, do those cross?
So it's a good question, and there are some individuals who do seem to have both disorders. My experience, though, and a lot of the literature points to the idea that bipolar illness is often, or borderline personality rather, is often misdiagnosed as rapid cycling bipolar illness. So the key to differentiating these illnesses is you see mood swings, of course, in both illnesses, but the mood swings that occur in borderline disorders are almost always relationally driven. So my partner isn't treating me well. I feel rejected by my partner, and now I'm depressed. Now I'm feeling suicidal. Whereas in true classic bipolar illness, the patient will wake up and go into a deep, dark depression for no reason at all. And they may stay depressed for months. Whereas borderline patients characteristically can express feelings of depression 1 hour, and the next hour they're laughing and they're out and they have a totally different outlook on life.
With that said, what are common signs and symptoms? So how would you know if you or someone you're with has one of these personality disorders? Is there like a right in your face symptom?
Yeah, it's really hard to say, and I'm not a huge fan of self-diagnosis. I think we are obviously very biased observers when it comes to our own
Of
lives and
course.
our own selves. And best piece of advice there is get yourself into a trusted mental health professional who knows these conditions and knows them well. If you find yourself I think a hallmark of the cluster B disorders generally is very unstable interpersonal relationships. If you find yourself in conflict frequently with other people, romantic partners, bosses, friendships, in healthy psychological functioning, you're getting along most of the time with most people you come into contact with. If you find yourself in conflict over and over again, if you find yourself repeating patterns with your partners, with different partners over time, this always seems to happen. They always leave me and I don't understand why. Or I always seem to be driving people away. Or people are always complaining that I'm so self-centered and all I want to do is talk about myself and I think I'm the best thing in the world. Then if you're hearing this repeatedly from different people, then maybe it's time to look in the mirror.
What about it's never my fault? It's always someone else.
Yeah. So these are what we call externalizing defenses in psychoanalysis. Externalizing blame is a hallmark feature of both narcissistic and borderline disorders. This was first described by the psychoanalyst Sandor Ferenczi about 100 years ago, more than 100 years ago now, via a process he called identification with the aggressor. The abusing, the person who is the abuser will come to turn around and say, you are abusing me. This is a concept, again, called identification with the aggressor. It's always someone else's fault. I really have nothing to do with the outcomes that have occurred in my life. And unfortunately, there are a lot of therapists out there nowadays, as you may know. Jonathan Shedler talks about this a lot, the psychologist, who really think their role is just to validate and essentially sort of help the patient to see that, well, other people in my life are the problem, and I think this is very dangerous territory. I think the point of psychotherapy is a critical self-examination. What am I doing that's contributing to the problems in my life? Yeah.
Well, this is the $1,000,000 question. Are there any effective therapies or interventions or medications that help people with these disorders?
I'm glad you asked. So in terms of, we'll start with medication. Medications are used for borderline personality disorder. They are symptomatic treatments. No one actually believes they're actually treating the illness. So for the mood shifts, you might start the patient on a mood stabilizing medicine like lithium or Lamictal, and the patient may have some improvement in their mood instability, but they're really just, again, like symptomatic treatments, like taking an Advil for a headache or for a backache or something. They're not really treating the illness. Psychotherapy treats the illness. For narcissistic personality disorder, generally medications are not used. Psychotherapy is the treatment of choice. When it comes to borderline disorders, there's really two main categories. One is dialectical behavioral therapy, which was first outlined by Marsha Linehan, who, by the way, came out and acknowledged that she struggled with borderline personality disorder as an adolescent and young woman. Dialectical behavioral therapy is very much a skills building type of therapy, learning techniques to manage moods and regulate emotions, and it's a structured treatment. The other type of therapy, which is evidence-based, is transference-focused psychotherapy. This is based on psychoanalytic ideas, first described by Otto Kernberg, or outlined by Otto Kernberg, the psychiatrist I mentioned earlier. In transference-focused psychotherapy, the focus is on the relationship between the patient and the therapist, the transference. And the therapist is pointing out to the patient how the patterns that are coming out in therapy are also playing out in the patient's outside life. So you're treating me very much like you treat your husband or your wife or your spouse or your partner, right? And you're repeating these patterns with me. And here's what's really going on here. And so the transference is the focus. And this is also a treatment, by the way, for narcissistic personality disorder, transference focused psychotherapy in the psychoanalytic school.
What is the effectiveness of that treatment? I don't know if you have like a statistic right off.
Yeah. So, I will say generally, there is this sense, really, it's a misconception that both borderline and narcissistic disorders are untreatable. And even mental health professionals, you'll hear them say this, well, they'll always be this way. There's no point to doing therapy with them, that they're untreatable. Michael Stone, who recently passed away, psychiatrist in New York City, who did a lot of work on cluster B personality disorders. He did the longest ever longitudinal study of borderline personality disorder, following some patients in the study over 50 years. These were patients in his private practice in New York City. Stone just recently died. I think he was in his 90s, just like last month or 2 months ago. But anyway, he concluded with this 50-year follow-up study that about 2/3 of borderline patients eventually reach meaningful recovery, either clinical remission, meaning they no longer meet criteria, or meaningful recovery. And the natural course of borderline personality disorder is actually improvement. This is one of the rare psychiatric illnesses that actually does get better in time, even without treatment. So often you see a person who in their 20s or their 30s looks very borderline. Once they reach their 40s or their 50s, the symptoms seem to burn out. Many of the symptoms, particularly the symptoms in the interpersonal domain. Narcissism. It's not. I don't really know. I don't have a hypothesis off the top of my head here on this. I think often, as human beings, we do reflect on things that we do and the patterns that have played out in our lives. And I do wonder whether it's just a function of realizing that this has happened so often in my life. There must be something that I'm doing wrong. There must be something that's happening here. And perhaps for that reason, perhaps it's a artifact in the sense that maybe relationships in general are not as intense when we're in our 40s or our 50s than they were when we were in our 20s or so. So different ideas, perhaps. Narcissistic personality disorder is difficult to treat. Both conditions are difficult to treat, but there is good reason clinically to suspect that narcissistic patients with intense psychotherapy, usually lasting years, and I'm talking on the order of 4, 5, 6 years of treatment, can improve. And patients can get better. I actually just talked to Frank Yeomans, who's a leader in the treatment of narcissistic personality for my role at Carlat, and he agreed that usually this is a very lengthy process, and but narcissistic patients can get better as well.
They can get better with years of intense psychotherapy. So there's hope. There's hope for every disorder, every diagnosis. What are the suicide rates for personality disorders? And I know your main study is borderline, so.
Yeah, so about 10% of borderline patients will end their own lives, will die by suicide. I don't have a figure on narcissistic disorders, although I believe it's generally accepted that that figure is much lower.
Yeah, that's what I was going to say. If they have a grandiose view of themselves, I don't think they would. Yeah.
Correct. But there is often a depressive flavor to narcissistic personality disorder that's all overlooked. But, when it comes to borderline disorder, so often you hear, oh, they're not really going to do it. And suicidal threats and gestures and expressing suicidal thoughts is very common in borderline disorders. And often this plays out in the context of that push-pull pattern that I described. Oh, my partner's not paying attention to me, or my partner's hurt me. I'm going to tell him or her that I'm just going to kill myself. And then he'll come over to save me or to rescue me. That's another dynamic in relationships, is a rescue. Often the partner has a rescue fantasy. I want to rescue you and save you. But it's not entirely true that borderline patients will just threaten suicide. Often suicide, in my experience in borderline patients, is done very impulsively. It's a split-second decision when there is intense pain. When someone leaves the borderline patient, it feels like existential death. It feels like I am dying. And in those moments, the borderline patient may be so impulsive that they will take an overdose, or they will do something to actually end their lives. They're not attempting to manipulate or anything like that. And thus we have to take that seriously. I think a lot of mental health professionals get into trouble when they start to believe, well, because this patient has threatened suicide or made suicidal gestures 10 times before, they're never actually going to do it. And sometimes on that 11th time, they will do it.
Yes. And I would hope a mental health therapist would never, and I know they do, would never say that they won't do it. Yes, of course they would. A couple more questions. I could talk about this for about 4 more hours, but how do comorbid conditions like depression and anxiety interact with these disorders? Because now you're and we talked a little bit about the bipolar and this as well, but now you've got depression, anxiety, and now you've got the borderline and the narcissistic tendencies.
Yeah. So when it comes to borderline personality, these individuals are very prone to shifts in their mood, again, often within the relational context, and in intense feelings of anxiety, again, often linked to interpersonal relationships, incredible anxiety about whether the person they just met a week ago is in love with them, and the like. So high overlap with what we might call, generally speaking, depression and anxiety. The way that I conceptualize these quote unquote comorbid problems as actually being part of the borderline syndrome itself. It doesn't mean that you shouldn't or you couldn't treat these problems with medication. You can, perhaps in some cases, anxiolytic treatment is effective for the anxiety that you see in borderline personality disorder. But when we start to talk about comorbid problems in BPD, very often I think we're talking about problems that are secondary to the borderline disorder. So you will see, as a part of the illness, shifts in mood, depressed mood, again, that usually resolves pretty quickly when there is some resolution in the relational problems, or otherwise, transient shifts in mood, and then also anxiety that is sort of part of the borderline syndrome.
What does the brain look like? What's the difference if you look at the brain of the borderline or the personality disorder compared to someone who is quote unquote normal?
Yeah, so I'm not a biological researcher, but I do know that there's been studies that have shown overactivation, I believe, in the amygdala, which is sort of our emotional center in the brain. One of the most fascinating pieces of research that I've come across on borderline disorders involves, that's sort of biological, involves the intranasal administration of oxytocin. People probably know oxytocin as the love hormone, yes, right? When we're falling in love, our brain is flooded with oxytocin. So what they did was they looked at patients diagnosed with borderline personality disorder versus healthy, quote unquote, healthy control subjects, people without borderline personality disorder, without any mental disorder. And they wanted to see what would happen in terms of their interaction with someone with whom they have to complete a task if they were given oxytocin intranasally. And what you saw in the healthy control subjects was that the study participants were engaged in more pro-social behavior, were more cooperative, and basically were better at achieving the task that the study authors had them do. When borderline patients are given oxytocin intranasally, there's more conflict, there is less pro-social behavior, and the ability to complete the task is diminished. Essentially, they stir things up, quote unquote, when they are administered this love hormone. And this is fascinating because, as I'm mentioning, as I mentioned earlier, borderline disorders are characterized by this push-pull. In addition to the fear of rejection and the fear of abandonment, is a fear of intimacy or enmeshment. So often the partner comes in closer. I love you so much. Please, let's do this. I want to commit myself to you forever. And the borderline patient, although expressing verbally those desires, does things to push the other person away, sabotages the relationship, engages in contradictory ways. And this biological research on oxytocin actually is quite intriguing, because as the borderline patient is, has induced this induced feeling of love, they're actually stirring things up.
How interesting. Just a couple more questions, I swear. So if you have a young child and maybe they got 50% of that genetic inheritance, but how do you make the environment safe to diminish the chances of your child developing these disorders or these characteristics?
It's a great question. I think that, when it comes to child rearing, what's most important, people have been writing about this sort of thing for 75 years or more, 100 years or more, right? Nurturance, warmth, comfort, love, protecting the child from assault, emotional or otherwise, from the other person. They engage in these destructive ways. And, I think also trying your best, if you're involved with the father in this case, for instance, to model some type of healthy co-parenting relationship, if that's the situation in which you find yourself, which with personality disordered patients is difficult. And I think often the people who know personality disorders best are not therapists, but divorce attorneys, interestingly enough. And you see this play out in full force in divorce proceedings and conflicts and parental rights conflicts in the law.
Absolutely, yes. Wow. One final question. What advice would you give family members of people who are either like in a relationship with someone with this disorder, or it's their son, it's their cousin? What advice would you give them?
It's a great question. I think, number one, get yourself into therapy. Get yourself into psychotherapy and talk about what's going on. Involving yourself with these types of individuals can be a very lonely experience. It can leave us confused and frightened, unsure of ourselves and whether we're losing our own minds. I think, so definitely get yourself into therapy. Evaluate realistically whether this is a relationship with someone with whom you would like to continue. And obviously that's perhaps a little bit simpler or easier when it's a romantic partner and not a child or a parent or something, in which there is perhaps some greater expectation that you maintain some sort of relationship over time. But yeah, and I think, there are online communities and support groups for victims and people who have been harmed by individuals with personality disorders. So you might find some help and some use in joining those groups.
Wonderful. Dr. Mark Ruffalo, you're phenomenal. If no one's told you that yet today, I'm telling you, you are absolutely amazing. Our very own psychotherapist here in Tampa. We're so lucky to have you here. And you teach. The students are so lucky to have you. Tell the listeners how they could find you, what your practice website is.
Yeah, I'm flattered. Thank you for those compliments. My practice website is drruffalo.com, drruffalo.com. If you're located in the state of Florida, I can consult with you professionally and perhaps work with you in psychotherapy. If you're outside of the state of Florida, I do second opinion evaluations and provide information for your treating provider in your home state. I can't legally practice psychotherapy, but yes, and my email address for those who want to reach me directly is mlruffalo@gmail.com, and I'm also on Twitter or X as @MarkLRuffalo.
Oh, you're on X. I got to get on there. Well, if anything you heard today resonates with you, if that sounds really familiar, please reach out to him. He is an absolute expert on this, and I would trust him 1000%. Thank you to my listeners for tuning in. It is because of you that we can continue to have this podcast. And we are here at the Just Help Out Mindset podcast, where we are breaking the stigma surrounding mental health one episode at a time. Please tune in next week for another episode of the Just Help Out Mindset podcast.